Good afternoon, ladies and gentlemen. It is May 15, 2018, 4 p.m. Central European Time, and it's my great pleasure to welcome you to the webinar organized by the European Reference Kidney Network, coordinated by Professor Franz Schäfer from Heidelberg. The topic of today is Hyperoxaluria, more than a stone disease, which will be presented by Dr. Jaap Groothoff from Amsterdam Medical Center. My name is Elena Levchenko. I'm a pediatric nephrologist from Belgium, and I'm going to moderate this webinar out of my office in Leuven. During this webinar, the slides will be projected on your screen, and you will be able to send us your questions using the special tab on your attendee panel. Questions can be sent anytime during the presentation and will be answered at the end of the webinar. Please don't be shy and just ask your questions. Any questions are very much welcome. Let me now introduce in more detail the speaker of today. This is Professor Jaap Groothoff from Amsterdam, the Netherlands. Jaap studied in the University of Groningen, and he did his fellowship in pediatric nephrology in Amsterdam, in Nijmegen, and also in Great Ormond Street in London, guided by Professor Martin Barrett. He did his PhD thesis under the leadership of Professor Hugo Heijmans in Amsterdam, with the topic Late Effects of Renal Insufficiency in Children. Later on, he stayed as a consultant pediatric nephrologist in Amsterdam, and starting from 2011, he became the head of the Department of Pediatric Nephrology in Amsterdam. Jaap has many different research topics, and one of these topics is hyperoxaluria. And nowadays, he is a chairman of the consortium Oxaleurope steering committee. So today, the topic of the presentation will be hyperoxaluria, just I have mentioned, and I think now it's time to give the word to Jaap, and he's going to start his presentation. Jaap, please, we are eager to hear your talk.
Thank you very much, Elena, for your very nice introduction. Hello, everyone. I hope in the next 35 minutes to give you an overview of the pathophysiology and clinical appearance of PH, and we'll try to demonstrate some of the diagnostic and therapeutic challenges that both physicians of adults and children may face when confronted with PH patients. Now, I have the disclosure that I'm a bit excited as this is my first webinar ever, and I was thrilled that so many of you prescribed, so I hope you will enjoy it. And you can see the other disclosure on this slide. Now let's start with a short movie on a typical Dutch family visiting an animal park, and I hope the sound will be good. Now, remember that confident face of the father, but probably mimics the state of mind of Mrs. A, and also probably her physician, who was referred to us in 2009 for a second opinion, and she was screened for metabolic kidney disease because of relapsing kidney stones in 1991, and she had a very good physician because he not only assessed the calcium creatinine ratio, but also oxalate and glycolate, and she turns out to have a very low calcium creatinine ratio, but a high oxalate and high glycolate excretion, which is consistent with primary hyperoxaluria type 1. And she was prescribed vitamin B6 and hyperhydration, and look at her course, which was quite favorable. She had only one stone event, which was removed after 10 years. And at the time we saw her, we could demonstrate that she has the most common mutation, the glycine 170 arginine mutation, which is consistent with B6 sensitivity. But why did she get stones at all if she had such a low calcium excretion? So let's focus on oxalate. The words come from oxalis, which is Latin for wood sorrel. You see in the background, it's a plant which is loaded with oxalate, like rhubarb and spinach and chocolates, which are other food components which has a high amount of oxalate. Now, oxalate has the nasty habit of that it very easily precipitates with calcium to a totally insoluble salt, leading to kidney stones and nephrocalcinosis. So it not only derives from your diet, but important source is the endogenous formation by metabolization of sugars and amino acids, and the most important ones are hydroxyproline and glycolate. But it's also an important breakdown product of ascorbic acid, and under normal circumstances, actually the dietary uptake is not very important when it comes to stone formation, but that becomes important if you have a fat malabsorption like in IBD and a short bowel syndrome, and you should always check these patients and monitor these patients for secondary hyperoxaluria. In fact, only a month ago, we had a 34-year-old patient with IBD and end-stage renal disease due to Crohn's disease. But under normal circumstances, it's very hard to get oxalate stones, but it is possible if you challenge the system, as being shown by this case report from about a 56-year-old male with acute renal failure due to 4 liters of iced tea daily intake, and he turned out to have an oxalate tubular interstitial nephritis, but this is a very rare situation. And here you can see his oxalate crystals in his kidney. So there are some important inhibitors of calcium oxalate crystals, where citrate is by far the most important inhibitor. It has a competition with oxalate in the binding of calcium, but it forms a soluble complex. And there is another huge advantage of prescription of citrate, that it has been shown to be protective against cell injury due to the oxalate-induced cytotoxicity in the kidney, in the tubular interstitial tissue, by preventing lipid peroxidation. The other important inhibitor of the formation of calcium oxalate crystals is magnesium. Magnesium oxalate is over 500 times more soluble, but it is less suitable as a therapy because it causes diarrhea and you need very high doses. Now, just have a look at the metabolism of the amino acids which are involved in oxalate formation. We now think that hydroxyproline and glycolate are the most important precursors, and both lead to the formation of glyoxylate, which is under normal circumstances very rapidly metabolized into glycine in the peroxisome. So under normal circumstances, there's only a very small proportion of cytosolic glyoxylate which is oxidized to oxalate. But that's completely different in PH1 patients. PH1 is a peroxisomal disease with the deficiency of alanine glyoxylate aminotransferase AGT, and see what happens if you lack this enzyme. Glyoxylate is accumulated, and then you get a high level of glyoxylate in the cytosol, which is oxidized to oxalate. And the other effect is that it is also reduced to glycolate. So, and that's the reason why glycolate is the biomarker of PH1. But you can also see here this enzyme glycolate oxidase, if this is a very potent enzyme in a certain patient, then you can have a situation where glycolate is very easily metabolized, and you can miss the diagnosed PH1 in these patients. Now, there are very many mutations now known in PH1, and they have all different biochemical phenotype. They can lead to a situation where the AGT is not produced at all, so you won't find any immune reactivity in a liver biopsy. Another situation is that there is a production of the protein, but it is inactive. And but the most common and the most interesting situation is there where there is a production of protein. It has a catalytic activity, but it is not metabolic activity purely due to the fact that it has a wrong postal code. It is mistargeted to the mitochondrion. And this very bizarre situation actually occurs quite often. And the situation is that it requires a combined presence of a common polymorphism, the proline 11 leucine polymorphism, which exists in about 20% of the Western population, in combination with the presence of a disease-specific point mutation, and the most common one is the glycine 170 arginine mutation. Well, and now we know that there are already other point mutations which has the same effects. But this combination leads to an unfolding of the AGT protein, as you can see here, and an impaired dimerization, and that gives a different postal code and leads to a mitochondrial targeting. Well, the good thing is that this whole process can be reversed, and sometimes nearly completely reversed, by vitamin B6, which is a precursor of PLP. We can see here is pivotal in the structure of the protein. And this is the reason why many patients with this mutation show a lowering or even normalization of oxalate excretion on B6 therapy, and that occurs in about 30% of patients in Western Europe. Now have a look at PH2. This is caused by a cytosolic enzyme defect of the glyoxylate reductase enzyme that leads to an accumulation of cytosolic glyoxylate, a low level of glycolate, but also a high level of oxalate, but also is this enzyme needed for the reduction of hydroxypyruvate, and this leads to a production of L-glycerate, which is the biomarker of PH2. Now, PH3 is the most mysterious one and also the newest pH, only recently explored, and it turned out that it is caused by a mitochondrial deficiency of hydroxyoxalate aldolase, HOGA, as you can see here, and that leads to an accumulation of hydroxyoxalate, HOG, and to date we don't know why this actually leads to hyperoxaluria. So there are two hypotheses. The first hypothesis is that it has an inhibitory effect on GR, and that would mean that it causes a PH2-like biochemical phenotype. The other hypothesis is that it is diverted to glyoxylate in the cytosol by a so far uncommon pathway, and both will lead to hyperoxaluria. Now, there is some circumstantial evidence of the first hypothesis, and it comes from the group of Holmes. Sonja Fark challenged patients and controls with labeled hydroxyproline, and what she actually saw is that in the pH2 and pH3 patients, there was a sharp and important increase in oxalate excretion, which did not occur in pH1 and controls. And what she also saw that both pH2 and pH3 patients kept very low glycolate levels, and this is consistent with the inhibition of GR. Now, what are the symptoms at diagnosis? These are data from the Oxaleurope database on more than 1,200 pH patients, and you can see that kidney stones are by far the most common first symptoms at time of diagnosis, followed by nephrocalcinosis, but which is far more important that you can see that more than 45% had already end-stage renal disease at time of diagnosis. And this mimics the well-known picture of an infantile form. I started my whole career with this patient who was referred to our hospital in '92 with end-stage renal disease and a complete white kidneys on ultrasound with a very high plasma oxalate level and high plasma glycolate level. Now, A turned out to have a brother who was 4 years old at that time, but had already hematuria at the age of 6 months. Unfortunately, the diagnosis was missed at that time, but he turned out to have still have medullary nephrocalcinosis and very high oxalate and glycolate excretion. And here you can see the difference between the two boys with the complete white kidney of A with end-stage renal disease and of his brother 4 years later. Now, K was very fortunate because he had a normalization of his oxalate excretion and a complete disappearance of nephrocalcinosis, and both children had the same mutation, and that is again the well-known G170 arginine mutation. But look at the course of A, which was quite unfavorable. We had to wait for 4 years before we could give him a liver and a kidney transplant due to insurance problems, and he had an immediate kidney graft failure due to hyperoxaluria. Then we gave him a second kidney in 2 years later, and look at the course that it took 7.5 years after liver transplantation and 5.5 years after kidney transplantation before his oxalate excretion normalized. So in 2014 he had a failure of his second kidney, and in 2017 he got his third kidney. Now Bergstrahl tried to find to establish an idea how many years it would take to mobilize all your stored oxalate, and he came to the rule of thumb that the years on dialysis would be equal to those years of mobilization. But of course, that is very dependent on the extent of dialysis treatments you give the patient, and now we know that you should actually put patients on daily hemodialysis for at least 4 to 6 hours to have a break even with the production. So this slide shows the impact of systemic oxalosis in A. He had 26 fractures. He had an impaired vision due to retinopathy. This is a picture of his eyes. He had a severe growth retardation, hearing loss, and also some mental retardation of his mental development. And here you can see how devastating systemic oxalosis can be. This is in a boy after 4 years of very inadequate dialysis, who came to us only weighing 30 kilos and had a complete destructed bone. So what is the clinical threshold? When does systemic oxalosis occur? And the honest answer is we don't know. We think that at an eGFR below 40, you have to really take into account that there might be systemic oxalosis. And we also think that above the plasma oxalate levels of 30, this will occur. But due to the inadequate tools we have right now to establish oxalosis, if you really see it on an X-ray, then you if you look into the eyes, you have a very advanced disease. So this is really a field for further research. Now, the diagnosis is very straightforward, based on 24 hours urine collection. If you have a child with a kidney stone, we recommend to always perform a metabolic analysis. But also if you have an adult with recurrent disease, if they have more than 2 stone events, they should have a metabolic workup. And if you will find an oxalate excretion of more than 0.5 millimoles oxalate per day, or more than 0.6 millimoles per mole creatinine, you should first exclude secondary hyperoxaluria, and then you look for the other metabolites, and that gives you a direction which kind of DNA assessment you have to perform to assess diagnosis. In patients with eGFR below 60, we recommend to do a plasma oxalate assessment, and if possible, a plasma glycolate assessment, because that gives you a monitoring device, and screen for systemic oxalosis, especially the eye, the bone, and the heart. But there are some pitfalls, important pitfalls. This picture is from a study of the group of Jill Rumsby, who followed 27 patients, PH1 patients, and followed consecutive urine collection, and she found on average a mean reference change value of 32%, and that result implies that on average a reduction of almost a third in urine oxalate excretion is required to prove an effect from a new treatment. But it also implies that a nearly normal excretion in one sample means nothing, and you can miss the diagnosis. Another hurdle is that in a bottle, a bottle of urine, calcium oxalate very easily precipitates. If you don't assess a proper acidification, you can have an underdetection of oxalate excretion. On the other hand, there's a problem of conversion of ascorbic acid in the urine, which can lead to an overdetection. And this is the reason why we say you should do at least 3 consecutive 24 hours urine collection to assess this. Now, classically, the classical therapy on the phenotype is that there are 3 phenotypes to be distinguished. There's the infantile form, which is supposed to be 100% unfavorable, with in nearly all patients direct end-stage renal disease. There's the more common juvenile form with kidney stones and nephrocalcinosis and a high chance for late renal failure. And there is the late onset disease, which is supposed to be mild with only occasional stone passage, like in Mrs. A. But should we be so confident as Mrs. A might have been, and this family? Look at what happened in the family. Now, Mrs. A turned out to have a sister, Mrs. B, and she was referred in '98 with a moderate renal dysfunction due to nephrocalcinosis. She had a long history of kidney stones, and even she had had a work of primary hyperoxaluria, but she was lost to follow up, and she had no contact with her sister, and she ended up with end-stage renal disease in the same year. She turned out to have the same well-known mutations, which was B6 sensitive, and she got a kidney transplant in 2000. And after 5 years, she still had a reasonable function with some oxalate deposition in the graft and slightly increased oxalate excretion. Well, this mimics a more recent case which came to our hospital, Miss J, age 63, also with a very long history of stone disease, an awful lot of urologic interventions, no diagnostics, even when he has a mild CKD, and then he got progressive unexplained vision impairment in 2012, and in last year he ended up with end-stage renal disease due to oxalate nephropathy. And he turned out to have 2 mutations, all associated with B6 sensitivity. And under B6 therapy, his plasma oxalate lowered from 133 micromoles per liter to 67 micromoles per liter. And he had a normalization of his plasma glycolate. Now, we gathered data of more than 1,200 PH patients in the Oxaleurope database, and here you can see the countries which are connected to the consortium, and here you can see the prevalence rate in several countries, and you can see that most patients have pH1 and 9% pH2 and 6% had pH3. Now, this picture shows on the first 2 rows the age distribution of the first symptoms and of diagnosis in pH1, and in the last 2 rows the same of pH2. And what you can see from the blue bars is that in most patients the first diagnosis occur at childhood, but look at how many patients already are diagnosed in adulthood. And that is probably the reason why so many patients, nearly 47%, already had end-stage renal disease at time of diagnosis, according to this database, and that nearly 74% of patients who were diagnosed over the age of 18 had end-stage renal disease at time of diagnosis. Now, we always thought that pH2 was a benign disease, but here you can see that nearly 20% ends up with end-stage renal disease and 40% with CKD. Now, what can we do? We still only have very limited therapy. Water is extremely important, and prevention of dehydration is pivotal to prevent them from end-stage renal disease. Potassium citrate has really demonstrated to be beneficial for all patients, and as you can see, some patients respond very well to B6, and we recommend to start with high doses and then taper down, because there's a huge variability between patients who are B6 sensitive in the need of the dosage of B6. Now, if you have a patient with an eGFR of less than 40, it's recommended to perform a liver transplantation or a combined liver-kidney transplant. If you have, however, a patient who is only diagnosed in dialysis, one can think of a sequential liver-kidney transplantation, or do it with directly combined with a very proper monitoring of the plasma oxalate level and perform CVVH during the operation. However, if you have a dialysis patient who turned out to be very sensitive to B6, you can consider to do only a kidney transplantation. This is from a Groningen study showing what the effect is of CVEH during a procedure of liver kidney transplantation in 2 patients, and can see that the plasma oxalate levels are kept to a very acceptable low level. And here you can see what happens if you perform only hemodialysis or short period of CVVHD or long periods of CVHD, and the dotted line depicts the oxalate levels in case of an absent renal function. So this underscores the need of long a prolonged period of CVHD if you have delayed graft function of your kidney. But of course, you want to prevent it, and we have waited for years, and now suddenly there are emerging new therapies. And I'm only going to discuss the substrate reduction therapy because there are now 2 phase 2 trials going on with this therapy. Well, the whole idea is to prevent oxalate production by inhibit one of its precursors, and the method both industries are using is the so-called RNA interference technique, which leads to an inhibition of protein production. Now, how does that work? The idea is that you fabricate a double-stranded RNA, and it is brought to the cell by a certain factor. And in the cell, it's cleaved by dicer into small single fragments, and that's the RNA, and is bound to activating elements called an RNA-inducing silencing complex risk formation. And this binds to the messenger RNA of the protein, which encodes for the protein that you actually want to eliminate. And it cleaves the messenger RNA and makes it ineffective. Now, the most common used vector now, but used by both firms, is N-acetylgalactosamine. That's a sugar ligand that conjugates the RNA, and it has the advantage that it is liver specific. It doesn't go to any other organ. And there's a high expression in hepatocytes of the receptor. And it also makes the therapy very easily applicable by a subcutaneous injection. So the first of the 2 therapies is directed against glycolate oxidase. And if you block this enzyme, then there will be no peroxisomal production of glyoxylate, which leads to also a low level of glyoxylate into the cytosol, and that leads to a decrease in oxalate accretion, but also to a further increase of glycolate. Now, how is that tolerated? We know from a report from a family from the Middle East who are all homozygous for GO1 loss of function, and these people have very high glycolate excretion with a normal phenotype with no symptoms. Also in mice it proved to be safe, and they showed here that if you have an AGT knockout mice, so that is a model for PH1, if you give them this RNA, you get an increase in glycolate and a decrease of oxalate. The second is targeted to the LDH, which is needed for the oxidation of glyoxylate to oxalate, and it is the hypothesis is the LDHA is the final common pathway, and it means that this therapy would be a therapy for all types of pH. Well, they have shown in mice model that it actually works, and they claim it's even more effective than GL blockade. And there are several reports with LDHA deficiency families with no phenotype. So I will come to my conclusion of my talk, and I think it's pH is still very importantly under-detected. There are some promising new therapy, but we have to be careful selecting these patients. The diagnosis can be very easily missed due to a high variation in oxalate excretion and improper assessment. Adult diagnosed pH is associated with adverse outcome, and in pH1, 2/3 has end-stage renal disease at follow-up, also in B6 positive patient, but this appears later on in life than in other mutations. And so my final conclusion is that primary hyperoxaluria is never a benign disease, even when the symptoms are mild, and you shouldn't be so confident as this family. I'd like to thank you very much for your attention, and would remind you for the next webinar is in June, given by Gemma Ariceta from Barcelona on familial hypermagnesemia with hypercalciuria and nephrocalcinosis. Thank you very much, and happy to take your questions.
Thank you very much, Professor Groothoff, for this very clear and nice presentation. So I see that there are some questions. I'll try to see them. So there is a question from Dr. Selçuk from Yüksel, and the question is about the needs of the biopsies for the diagnosis of hyperoxaluria, and he asked whether you can show this disease by demonstrating oxalate crystals in kidney biopsy, and whether you need some special methods for staining.
Normally, in most patients, a biopsy is not necessary. So the biopsies performed is usually in patients with end-stage renal disease for uncommon reason. In a situation where the assessment of urine oxalate is not possible. And the examples in my talk, these were all patients found by coincidence by the pathologist. And it also means that you will very easily detect it if it's there, even when you don't expect it, because all these patients were not expected to have hyperoxaluria. They were also all found by coincidence. So at least that is what my pathologists always say, you can't miss it.
Okay, thank you very much. Please ask other questions. In the meantime, maybe I can ask you a question. So you have shown that there is a huge difference in the severity of the phenotype between the patients, even within the same family. So maybe you can speculate about the reasons for that. Maybe there are some modifying factors, genetic or others.
Well, this is one of the most important questions. But I do think that you can be unlucky. I think you can be unlucky due to circumstances of dehydration. We have seen that nearly all patients who have a suddenly deterioration of kidney function have experienced a period of dehydration due to gastroenteritis or something like that. And the reason why I think this is very important is that even in patients who have end-stage renal disease, they respond very well on sometimes very well on B6 therapy. So you can as easy bring down your oxalate excretion in these patients as well as in the family members who have a more fortunate and more favorable course. So it might be that circumstances in daily life might be more important than it's actually a genetic factor which we haven't discovered, but we are not sure.
Okay, thank you very much. We have another question from Graham Smith from UK. So the question is the following: a problem we find with children with stone disease is an unwillingness to take the potassium citrate preparations available.
Yeah.
So we ask whether there are some tablet forms which are very expensive, and whether there are some new developments on that.
No, I think that's a very good question, and the problem is that now with the other new therapies, there's less focus on citrates, which I think is unfortunate. Citrate might be far more important than we think, because there's another observation that citrate levels are especially low in PH1 patients and not in the other ones who have more favorable course. So citrate might be far more important than we think right now, and I think it would be an option to look for long-lasting potassium citrate tablets, which are much easier to take than the current pills that we have. So I agree with the fact that this is really a problem in daily practice.
Okay, thank you very much. Another question is from Dr. Ahila Hassan. The question is regarding their transplantation policy in Hyperoxaluria. So if you have a child with primary Hyperoxaluria type 1 with a CKD stage 4, would you prefer doing a combined liver-kidney transplantation? Because if you do a sequential transplantation, liver first and then the kidney, then you can have the worsening of the kidney function because of the use of immunosuppressive therapy. And on the other hand, it can be preferential to have the same donor for the liver and kidney.
Yes, these are very difficult questions, and this is, I think, this always should be personalized medicine. If it is a CKD stage 4 and not 5, so there is residual renal function, and you don't have massive occurrence of storage, then I would advise a directly combined liver-kidney transplant. And but you should always have a very good monitoring of your plasma oxalate levels during the procedure, and very easily start with CVVA therapy during the procedure if you don't have an immediate graft function of your kidney. I think that is pivotal, and that's something which went wrong in our patients in the early 90s. So yes, I think I would recommend a combined, but you should, all these cases, you should know all the details to come to a good solution, whether it should be combined or sequential.
Okay, again, thank you very much. So we have the same the question from the same Dr. Hassan. So he's going on with the same topic regarding if you go on with combined liver and kidney transplant from the deceased donor, how many months of dialysis, I think means in intensified dialysis, would you recommend to reduce the oxalate load?
This is also a difficult question. Also depends on the history. If it was a child who had, for all kind of reason, been for a long time on dialysis before the liver transplantation, you should wait longer than if you have only have had a very short period of dialysis. It also depends on the monitoring of your plasma oxalate, which is difficult because the plasma oxalate level doesn't, is not a pure reflection of how many is stored, but you should see how rapidly it reoccurs after dialysis sessions, and what actually the cause of the plasma oxalate level is, to establish the moment of kidney transplantation. So for instance, if you have a patient for only 2 or 3 months on dialysis, and you have them on very frequent hemodialysis, you can even think of a directly combined, and if you would do a sequential, then you could plan the kidney transplant in 6 to 12 months. But if it will is a patient who has been on a very long period of dialysis, for what kind of reasons, I think you should take longer.
Okay, again, thank you very much. I think these are very difficult questions. Maybe I have another question regarding these novel therapies. Which categories of patients, in your opinion, would benefit most from these novel substrate reduction therapies? Most severe patients, or patients with lighter forms of the disease? Or what would you think? Where there is a place for these novel therapies where they eventually come to the market?
Well, these therapies, of course, will become very, very expensive. And I think we should first start with patients who have impaired renal function or a very high burden of disease. For instance, I have a young woman who has eGFR of 60, no, 45, 50. But she has so many very severe stone events, which and a need for surgical intervention nearly every other month. I think these kind of patients would be eligible for this kind of therapy, and the very severe ones. I think we should be cautious with the B6 positive ones, and see how they respond on B6 therapy, and follow them monitor them very carefully. But I would not recommend to apply these therapies immediately on these kind of patients. But they should be monitored, and because we know if they can also have an adverse outcome on the long run.
Okay, thank you very much. I think we have to finish this webinar by thanking you for this very nice and very clear presentation on this difficult topic. I would like to thank all for being with us. For those of us who would like to see the webinar again, it was recorded and it will be published on the website of ERKNet. And please don't forget to register to our next webinar on the 5th of June. Thank you so much. Thank you. The webinar is closed.